So Phaedra is a graduate of the medical school at the University of Toronto. She did her residency in OB-GYN at Queen's University. She then spent a 2-year fellowship in urogynecology and spent quite a bit of time with Dr. William Easton, who's back there, who started the urogynecology program here at Root Valley. And she now shares her practice with Bill, and her areas of interest include minimally invasive procedures for the treatment of prolapse and incontinence. Phaedra.
Good morning. Thanks to those who are staying. I know we're running a little bit behind. So the nice thing about going last is that the caffeine has had time to hit your brain. The worst thing about going last is that now the caffeine has also hit your bladder as you sit through a continent. So if you need to use the washroom, I completely understand. All right. So first of all, I really have nothing to disclose in terms of interest or commercial support. Potential bias. My objectives are pretty simple. There's only two. I'm going to hope that by the end of this talk, you'll be able to identify different types of urinary incontinence in the female population, and that you should be able to initiate management in the office for different types of female incontinence. I'm not going to talk about surgery today, but I'm happy to answer any questions about surgical procedures or mesh or anything after the talk. All right, so first of all, is this an important topic? And I think it is, because it's my full job. But it's going to become more and more an important topic because we know that this problem increases with age, and that the elderly population is the fastest increasing demographic in Canada. So it's people more than the age of 65, 55% of them, women over the age of 65 will suffer from some type of incontinence. And at least it's getting talked about more now. You can see the photo here is an ad campaign for incontinence pads with Whoopi Goldberg. So, 15 years ago, there were commercials featuring incontinence products for women. Now they're talking about it more. They're coming and asking for help more frequently, so I'm sure you're going to see it in your office. There's a significant impact on quality of life associated with incontinence. We know that it's associated with depression, and on quality of life indicators, it has the same impact as Alzheimer's and stroke. So it does have a significant impact on patients' lives. It's also very expensive. So the direct cost to a patient is about $1,500 a year, and that's for incontinence products. And then there are indirect costs to the system. So 11 million days of lost work, $1.5 billion in lost productivity, and the total cost is estimated at $5.6 billion a year to the Canadian healthcare system. So it's obviously an extremely important topic. All right, so I'm going to use a case to highlight some of the points that I think are important. This is Mrs. M.I. She's a 62-year-old gravid of 2 woman who comes to your office complaining of urine leakage over the last 6 years, worse in the last 6 months. She says she does leak with coughing and lapping, but it's really these episodes of not making it to the washroom in time that are bothering her the most. She is sexually active and she does have some dryness. She's quite healthy. She's got some controlled hypertension and some chronic constipation, but is not on an extensive list of medications. So just on her history alone, she's leaking. What type of incontinence does she have? There are many reasons that you can be incontinent, but I like to think of them in 3 sort of broad categories. Overflow incontinence is due to the bladder's inability to empty, either because of an obstruction or because the bladder has gotten lazy. It's actually quite uncommon in the female population unless you've had pelvic surgery previously. The more common types are stress incontinence and urge incontinence. Stress incontinence occurs because of a relaxed pelvic floor or an anatomic defect, such that leaking occurs with activity or with an increase in intra-abdominal pressure. To contrast, urge incontinence is when the detrusor muscle is contracting at times when you don't want it to, and causing urine leakage. On history, you can get a lot of these details to help you sort out which type of incontinence a patient has, but it's not perfect. So they'll usually describe stress incontinence as, again, leaking with coughing or sneezing. They void at normal intervals, so they don't have urinary frequency. They don't really have issues with nocturia, and they usually describe a small amount of urine leakage. And to contrast with urge incontinence, again, it's a sudden and compelling desire to pee, and they are fearful that they won't make it to the washroom. Precipitating factors are things like hearing running water, putting your hand on the doorknob when you come home from a shopping trip. They often have nocturia and increased urinary frequency, and they will tell you that they lose a large amount of urine, so they usually will soak through their clothes, although this isn't always necessarily the case. And again, overflow incontinence is a little bit more in common, so we'll just glaze over that for the interest of time. History can be unreliable, and the symptoms can be mixed. Sometimes patients have a hard time putting these symptoms into words, but history is where we start. With the physical exam, the most important thing is the cough stress test. I don't know if you can see the picture with the lights right now, but that's actually a picture of, there's urine flying out of the urethra with a cough. I can't take credit for getting this picture myself, this action shot. It was one of my mentors who got the picture, but that's what a positive cough stress test looks like. You'll see urine leakage with cough or Valsalva. Other important components of the physical exam are an assessment for pelvic organ prolapse and atrophy, as atrophy can also cause some urinary symptoms, and a neurological assessment is important if there are any associated symptoms. The basic investigations that should be done for urinary incontinence are post-void residual, which can most easily be done by an ultrasound, and this will help to weed out people that have voiding dysfunction or do have overflow incontinence. And also urine culture and urinalysis are important as they can mimic either form of incontinence. I also find a bladder diary helpful because it helps me to look in an organized fashion at what a patient's bladder habits are. I find it more useful for the patient because you say, oh, how much are you drinking? And they say, oh, not that much. How many coffees do you have? Oh, a couple. And then you see that they're drinking 8 coffees a day and having 4 liters of water before they go to bed. So it's a little bit of an introspective exercise for them as well. And I'll actually show a link where you can get bladder diaries just for free to print off, give to your patients in your office if it's something you're interested in. Okay, so back to our case. You examine her. There's no significant prolapse. She does have some atrophy, so it's, the mucosa is pale. There's no root A. She doesn't leak today with coughing or Valsalva, but she doesn't think she has a very full bladder. And of note, her BMI is 28. So you do an ultrasound. It shows a normal post-void residual, which is less than 20%, and her urinalysis and culture are negative. So just to go back to stress incontinence for a moment, again, the definition is loss of urine on effort or exertion, coughing or sneezing. As I mentioned, it's a structural problem, and the risk factors for the structural problem include things like vaginal delivery, increased parity, elevated BMI, smoking. We do know that there is an inherited component to stress incontinence. We may actually see it amongst different family members. Treatment for stress incontinence is aimed at correcting the anatomic defect. This can be done in a number of different ways. First and foremost, if a patient's BMI is greater than 25, there is evidence to suggest that you should counsel them regarding weight loss and that it may improve their urinary symptoms. Realistically, most patients have a BMI over 25, so really it's over 30 is when I start to counsel them about weight loss. Pelvic floor muscle exercises can work. You'll see I have a little caveat at the bottom, 20% cure, which sounds quite low, but 69% will notice an improvement if they actually do them, which is the real task. There's a number of different ways. You can tell a patient to do Kegel exercises and they'll go home and they won't ever do them. You have to ensure that they're doing them properly, and the only way to do that is to actually physically examine them as they're doing a Kegel exercise. You can feel the contraction. They get that positive feedback and they go home and they can do it. They have to do at least 30 a day. There's also a trick called the knack, which is where you teach the patient to do a Kegel exercise when they cough or sneeze, and that's supposed to help prevent urine leakage, and it will work in some cases. Another way to do pelvic floor exercises is biofeedback and physiotherapy, which is really great. Unfortunately, with the lack of coverage for physiotherapy, that's a big barrier for a lot of patients to be able to afford, but if it's covered, I would highly recommend it. And then finally, there's something called weighted vaginal cones, which was pictured in the bottom right. And for those of you who've never seen them, they look almost like the inside of a Kinder egg, and they have different size weights in them. The idea is the patient wears them inside twice a day for at least 30 minutes, and then they can increase the weight as they're able to do that without any trouble. And all of these ways of doing exercises have the same efficacy. It's just whether or not patients will actually do them or not. And the third option for conservative treatment is an incontinence device, which is different than surgery. There's one available in Canada right now. It's called the Aresta. The website is up top there, and it's similar to a pessary, but it's designed specifically with incontinence in mind. So you can see I've shown a little example of the device with the number 4 on it. It is made of medical grade non-latex rubber, and at the bottom right, hopefully you can see how it's actually positioned inside the vagina. So the widest part of the pessary is actually putting pressure on the bladder neck, so that when the patient does cough, laugh, jump on a trampoline, that hopefully will occlude the bladder, neck, and prevent any urine leakage. The nice thing about this is that patients can tailor their use. They can wear it just when they're doing things that cause leakage. They can wear it all day and take it out at night. It is meant to be taken out at night and not left in for extended periods of time. It can be purchased without a prescription. You don't even need access to a physician in order to get one. You just go online and buy it. The downside is that it is a bit expensive. It's $250 for a starter kit, which includes 3 sizes, so that the patient can go home and try to fit it themselves. And I recommend this to I let every patient with incontinence that I see know this device exists. Unfortunately, the uptake on it is very low because of the cost. There is a randomized control trial that was done, and it showed that 64% of patients were dry using the device versus 10 or 11% with the placebo. All right, now on to overactive bladder and urge incontinence. So overactive bladder is actually a symptom-based syndrome that's diagnosed by having at least one of the following: urgency, frequency, or nocturia. Urge incontinence is most bothersome to people when they have dry overactive bladder, so they just get the feeling that they're going to lose control, but they don't. They're not usually quite as bothered. Urge incontinence is the most common type of incontinence in the elderly. However, urgency isn't always overactive bladder, so there's a few other things to consider. One, obviously, is urinary tract infection. Atrophy can often mimic overactive bladder. Voiding dysfunction or significant prolapse that might be causing urinary retention can lead to urgency, and then other more rare conditions like interstitial cystitis, neurological disease, or bladder pathology such as malignancy. All right, so the initial treatment of overactive bladder, again, common sense sort of lifestyle modifications include drinking less water and not drinking caffeine. Pelvic floor exercises are also very helpful and very underused for overactive bladder. It's actually, it can demonstrate that doing a Kegel exercise will inhibit intertruser contractions, so teaching patients to do a Kegel exercise when they get that feeling of urgency can be very beneficial. Bladder training, I'll discuss more in a moment. And then there's medication, and there's a number of overactive bladder medications, which I'll go through briefly. And as well, it's important to remember that vaginal estrogen can help to treat atrophy and may also help patients with urgency. There's no evidence that it helps with stress incontinence, but it can help with overactive bladder. So bladder training is a great tool that's not used very much because it's quite labor intensive for the patient, and they'd rather take a pill most of the time. What you do with bladder training is you instruct the patient to void by the clock rather than when they get the urge. So for the first week, they tell you, I'm going to the washroom every hour. So you say, okay, you're going to go to the washroom every hour, whether you feel like you have to or not. And once you've been able to do that, the next week you're going to extend that to an hour and 15 minutes. And if you feel like you have to go before that hour and 15 minutes, you're going to try your best by doing a Kegel exercise, using other relaxation techniques to avoid using the washroom until you get to that hour and 15 mark. And then you do this gradually prolonging the interval slowly over time, and it's actually an extremely effective 40% decrease in weekly incontinence episodes. 40% might not sound like a lot, but when I show you the reduction with overactive bladder medications, you'll see that it's actually quite good. So I'm not going to go through this. I just wanted to highlight again that within the bladder, there's a number of different receptors, and these are what are the targets for the overactive bladder medications. With the exception of one, the medications all target the muscarinic receptor, the M3 receptor in the detrusor muscle. There is a medication that now targets the beta-adrenergic receptors, and so works slightly differently. They all work, however, by increasing bladder capacity and decreasing urgency. So you're probably familiar with most, if not all, of these medications. There's the pure anticholinergics, things like bezateridine, oxybutynin, and tolterodine in their various forms. There are selective M3 antimuscarinics, which theoretically should have less side effects since they're selective for the receptors in the bladder preferentially. And these are things like darafenacin and solifenacin, which you probably know as Enablex or Vesicare. There is a quaternary amine antimuscarinic, which is called trospium or Trosec. It's not used very often. It doesn't cross the blood-brain barrier, so it's a more popular choice for patients with cognitive impairment. And then finally, there's a newer medication that's a beta-3 adrenal receptor agonist called mirabegron or Myrbetriq, and that is the one that acts on the beta receptor rather than the muscarinic receptor. So I'll show it has a different side effect profile. So do they work? Statistically, yes, there's a statistically significant reduction in OAB symptoms for fewer leakage episodes per week. So statistically they work. How clinically significant that is up to the patient. And that's why combining it with behavioral therapy is the best way to see improved results. Adherence is actually low for these medications, usually due to the side effects, and only about 13% of people will continue on in that 1 year. All these medications have a similar efficacy, but they have different side effect profiles, and that is really what you should use to guide which medication you might recommend for a certain patient. Again, the side effects are due to the other anticholinergic receptors found in the body, and the most bothersome, most common ones are the dry eyes, dry mouth, and constipation. Specifically, there are a few considerations for patients with medical comorbidities. So you'll see that for patients with cardiac conditions, arrhythmias, Trospec or trospium and darafenacin or Enablex have been studied, the most well studied, and are considered safe for patients with cardiac conditions. It tells you here that most patients with cognitive impairment, it's safe to use any except for oxybutynin. But again, Trospec has been more well studied in that respect. And then for patients that are using cytochrome P450 inhibitors, again, trospium is considered to be the most safe. The immediate release formulations are usually associated with more side effects than the extended release or the transdermal forms. Mirabegron does not have the anticholinergic side effects and does not cross the blood-brain barrier in animal studies. And all of these medications are covered except Mirabegron, unless that has changed very recently because I've been on maternity leave. No, still not covered? Okay. Contraindications to overactive bladder medications. Anticholinergics, you can't use them with uncontrolled narrow angle glaucoma. You should avoid them in patients with gastric retention or those who are known to have a prolonged QT interval or an arrhythmia. Mirabegron, the only contraindication is severe hypertension, which they defined as 180 over 110. You have to be careful with patients that already are in urinary retention. Obviously, these medications have the potential to make that worse. Unless they're interested in self-catheterizing, they probably shouldn't use an overactive bladder medication. And then patients who are pregnant or have an allergy to any of the components should avoid. Here's my instructions to patients. I tell them they have to take it for a month to know that it's going to work. They're going to find the side effects way before that, but it takes at least 1 month to know if the medication is going to be effective for them. If there's a partial effect, we talk about increasing the dose. If there's no improvement after an adequate trial, again, at least a month, we can consider switching to a different medication. If it's working for them, I suggest they stay on it for 6 to 9 months. No one wants to hear they have to take it forever. I do tell them that they could try to wean themselves off of it and reassess their symptoms. If they're finding that their bladder symptoms are coming back, then they can start the medication again. I have patients come back in 3 months. Sometimes I get them to redo a bladder diary so they can actually see if it's helping or not. I don't routinely repeat their ultrasound. And just a word that both mixed incontinence, so stress and urge incontinence, can happen extremely frequently. I usually treat the most bothersome symptom first. So even if a patient has stress incontinence, if it's the urgency that bothers them the most, that's what I aim to treat first with the medication. And the behavioral changes and lifestyle modification will actually help with both types of incontinence. And again, those include things like the exercises and specifically bladder training. Okay, so back to our case. She has mixed incontinence, and in her case, the urgency component was significantly worse. So we would ensure that her Kegel technique is adequate, and I'd actually offer her vaginal estrogen to treat her atrophy, as this may improve her symptoms of urgency. So then I have her come back in 3 months, and she says, okay, yeah, my stress incontinence is actually better with those Kegels. I don't have to use as many pads. The dryness has improved using the vaginal estrogen, but I still have occasional episodes of leakage. When I come home from bingo, I put my hand on the doorknob and I can't control myself. So at this point, she's interested in a trial of overactive bladder medication. And again, we know she has a normal postvoid residual, so she doesn't have urine retention. She has a private drug plan, and her only issues were controlled hypertension and constipation. So she's really a good candidate for any of the medications. I would usually describe the side effect profiles of the medication to the patient and actually give them the choice as to which one you wanted to try. All right, when should you refer a patient with incontinence? Well, if they fail conservative management or they want to know about more invasive options. If they've had previous surgery for prolapse or incontinence, that can complicate the issue, and definitely happy to see patients in that scenario. Patients who have significant prolapse beyond the hymen will almost always have some kind of urinary retention, urgency, incontinence, and the prolapse needs to be treated as well. And then patients with a high postvoid residual, are at risk of recurrent UTIs and their voiding dysfunction, so they should be seen as well. So the IUGA is the International Urogynecology Association, and you can access their website for free. You don't have to be a member. And there's all of these handouts with really great information for patients. So handouts about stress incontinence, bladder training, the instruction sheet is there, so you don't have to explain to them what I just explained to you. There's examples of a blank bladder diaries. So I actually use these with every patient that comes to my office. They end up leaving with one of these pieces of paper, and it gives them something to look at when they're home, and the information is excellent. So I would encourage you to go on that website, just print off a few copies of each, and if you have patients with urinary issues, they're a really great patient resource. The Canadian Continence Foundation also has a website, which is great for patients. I was going to talk about nocturia, but since we are over in the essence of time, I can stop there. Yeah, okay, perfect. Thank you very much for your attention, and I'm happy to take any questions.
No questions? Okay.